Hello. Welcome, everyone, to Physicians Health Network. And we are physicians that are here for several reasons. Number one, we're here to improve the health of anyone of African descent. And number two, we are here to encourage young Black males to let them know that they can be doctors because we need them so badly in our community. This webinar is every second Saturday at 1 o'clock. And I must preface that because we missed a few Saturdays there. Number one, I think it was June we missed, and that was my fault because I was in Asia and I thought about you all that time, but Asia was so nice, I only thought about you once or twice. But and then August, we try to give the physicians a chance to go on vacation. So there were 2 months we missed, but we're back and we look forward to answering your medical questions. Understand that also you can go and see our prior webinars. All you have to do is go to OBHealthy and note that our webinar rather the web page, it has an area there that you can go into the YouTube channel, and all of our past webinars are there. And I trust you will go in and educate yourself about health because it's so important. The most important thing that I can say today is that please do not change any aspect of your medical care until you consult your physician. Only your personal doctor can truly take care of you from a medical standpoint. All right. Let me say also that I would like to thank OBHealthy for allowing us to bring this webinar to you. They are our sponsors, and I'm so appreciative of them allowing us to use their platform. Now today, we have a special guest today, and I can't say enough about him. I know he didn't think I was going to do this, but he is the past president of New Jersey Medical Association. He is the head and leader of the Caribbean Medical Mission. I mean, and he's my personal ophthalmologist. So, I got to give him the kudos for that. We are going to be talking about the eye, and that is Dr. Winston Scott is with us, and I am just so proud to have him with us today. Other than that, I think that let me make sure that I've covered everything. Yes, I have. And let me put my phone on mute because that is the background sound that you're hearing. And basically, we're ready. So let's introduce ourselves. We have several of the physicians here at this particular point. I know other physicians will be joining as we go on with the program. Dr. Scott, please introduce yourself.
Thank you, Omar. Dr. Bay, thank you so much for having me join this wonderful platform. And I am very pleased to be here. My name is Dr. Winston Scott. I'm an ophthalmologist. I'm also the chief of ophthalmology at Carewell Health Medical Center, formerly East Orange General Hospital. I've been in private practice in East Orange for, over 35 years. Just recently, I was joined in practice by my daughter, Dr. Jessica Scott, and she is subspecially trained in the medical and the surgical treatment of glaucoma. And I'm just so happy to be here, and I look forward to transferring as much information as I can to your audience.
All right, thank you very much. Dr. Court, you're on mute, Dr. Court.
Okay.
There you are.
Dr. James Court, my specialty is internal medicine. My practice is located in East Orange, New Jersey.
All righty. And we have other doctors that are joining us. Dr. Kendall Sprott, I think he's having a little technical problem, but he will straighten that out and we will introduce him soon as he does. Dr. Lawrence Daniels is with us, and I think he will be joining us he will be joining us very soon as well. Dr. Patrick Anderson stated that he's at the hospital. He'll be coming in soon. and Dr. Kevin Clark will be coming in as well. Dr. Kendall Sprott, please
Yes,
introduce
I'm
yourself.
Kendall Sprott, board certified pediatrician, now retired. Happy to be with my fellow brothers.
All righty, excellent, excellent. Well, we're going to get started on our topic. And Dr. Scott, you know, it's always important for our community to break it down and just, you know, talk and speak it, I should say, speak in a way or a language that they can understand. So can you explain a little bit about the eye, how it's put together, what it does for us, and, you know, just at the basic level, give us an education about the eye.
Okay, well, you know, you've heard the expression, the eye is the window to the soul. And anatomically, the eye is one of the most complex organ that we have, next to the brain, of course. And it starts with the very front of the eye called the cornea. And this is where, if you wear a contact lens, this is where you'd put it, right on the surface of the eye is called a cornea. And then you have the white part of the eye, which is called the sclera. And right over that sclera is a very thin layer with a lot of blood vessels called the conjunctiva. When someone get an infection or pink eye, it's that conjunctiva which has gotten infected, and those little tiny blood vessels that becomes more and more highlighted, and it gets very, very red. Now, behind the conjunctiva and behind the cornea is an area called the anterior chamber, and there's a lot of fluid that's made there. And the fluid is made, and as much fluid as made, it's also sent back out equally. And I'm going to talk a little bit about glaucoma shortly, but that dynamics of fluid being made and fluid going out is very important. It has to be in the exact balance. If too much fluid is built up, it can cause the pressure in the eye to rise, and that in itself can cause damage to the eye. Now, right behind that, you will have the iris that gives you color to the eye. And then in the middle of the iris is an area called the pupil, which is that little dark area in the middle of the eye, which when light hits it, it goes in and out. Behind that is an area called the lens. And the lens helps us to focus and see things well. When that lens is no longer focusing, we call it a cataract, and that can cause blurriness to your vision. Behind that lens, there's a gel-like substance called the vitreous. And the vitreous is what helps to keep the shape of the eye together. And this gel is attached to the back of the eye called the retina. The retina is nerve tissue where light and images come in. It sends a signal back to the brain, and the brain interprets it and lets you know what you're looking at and what you're seeing. And that nerve in the eye is called the optic nerve, and it's a direct connection to the brain. So the eye is a very complex organ. And of course, if you speak to most people, they'll tell you, I'd rather lose a limb than to lose my sight. That's how important the eyes are. But of course, we're all interconnected, so everything is connected together. But the eye is so important because there are certain diseases, and I'm going to talk a little bit about glaucoma. There's a disease called primary open angle glaucoma, where the fluid, as I say, it's being made and it drains out throughout the eye. It has to be in perfect balance. Now, glaucoma is the disease where there's not enough drainage and the fluid builds up. And as the fluid builds up, the pressure builds up and it causes damage to the eye, and the damage is permanent. Now, glaucoma happens to be the most common cause of blindness in Black people all over the world. Now, cataracts is the most common cause of blindness worldwide, but cataracts can be cured. You have cataracts, you remove it, you can see better. Glaucoma is the most common cause of irreversible blindness in African Americans and Africans in every part of this world, because the sight you lose is permanent. And the unfortunate thing is, when it's occurring, it has no symptoms. It's called the blind thief of sight. No symptoms. The eye doesn't get red. It doesn't hurt. That's the most common cause, is chronic open angle glaucoma. There is another type called angle closure glaucoma. It's not very common, but when it does occur, your eyes will get red. It can become painful, and it needs to be treated acutely because you will lose your sight very quickly. The more common type, open angle glaucoma, it's a very slow, insidious disease. You can have it for many, many years. You can start to lose some sight and not even know that you're losing sight. So it behooves you to go to your doctor, your eye doctor, and make sure your eyes is examined, your pressure is checked, and you are examined for glaucoma. Now, there's one thing I want to leave you with that you should definitely know about this disease, is the risk factors for this disease. Now, who's at risk to develop glaucoma? Just being African American, being Black, puts you at risk to develop glaucoma. If you have a family history of glaucoma, it puts you at risk for glaucoma. If you have high blood pressure, if you have diabetes, if you're over the age of 40, you are at risk for glaucoma. So more and more reason why you should go and see your doctor for your examination, for glaucoma workup, because early diagnosis and treatment is the best way we have to take care of this disease. I hope that's a start. We can go on to much more as we go forward.
Excellent, excellent. You know, the thing of it is that our audience is, I must say our audience is people of African descent for probably most of our audience. And when you start talking about a disease like this that is mostly asymptomatic, and there's a possibility of you losing your sight, it's so important. You know, the thing it is that most of us, we'll go to the doctor and we'll see if, you know, if I'm having blurred vision, or if I can't see the TV, or, you know, something like that, I'll go to the doctor. Or if I'm having trouble reading, but they won't go just to check, you know. As far as Dr. Court, do you recommend recommend for your patients on either a yearly basis at a certain age to go see the ophthalmologist? Is that how it? Tell me exactly how you get your patients to go see, or do most patients that come to you, there's a reason, and that's why you refer them, not as just on a yearly basis?
Well, most of the patients that I refer to an ophthalmologist, they come to me because of a reason. That they have maybe blurred vision, double vision, and the most common things that I see with the patients are like allergies, redness on the eyes, and some vision loss. In terms of what also happens in our case is that the insurance companies, especially patients who may have diabetes or high blood pressure, they always remind the patients that they have to have annual eye examinations. Right. So in addition to myself, the insurance companies also are very helpful in terms of getting the patients to come to be checked out.
Right.
But
Dr. Scott Winston, could you just tell the audience how the diagnosis of glaucoma is made and what they need to do in order to determine that you have glaucoma?
That was my question. Next
Yeah.
one.
Well, of course, the history is very, very important, and of course, the family history is crucial. Race, of course, plays a part because there's a genetic predisposition for the disease. So, in part of the history, part of that we can see. In addition to part of the history is, did anyone in your family lose sight for any unknown reason? They may not say they have glaucoma. They may say, Grandpa, oh, as he got older, he wasn't seen very good. You know, he just kind of lost the sight. If we don't know what caused Grandpa or your uncle to lose your sight, we're going to presume it's glaucoma until proven otherwise. So the history is very important. Medications, what medications are you on? Are you taking anything that contains steroid that can also cause the pressure to go up? And that may also be very subtle. The asthmatic, the allergic patient who's been using that pump over the years may have a little corticosteroid in it. Over the years, it's cumulative, and they can also put them at risk for glaucoma. Mm-hmm. Now, and as far as the physical examination, yes, we examine the eyes for the visual acuity, but glaucoma tends to affect more your peripheral vision than your central vision. Central vision can occur late. The peripheral vision is what the more subtle early signs of it, and sometimes no signs at all. But the early signs, the loss may be just peripheral. The patient vision may be very good. Sometimes I tell my patient that, you can have 20/20 vision and be considered legally blind. Now, it sounds counterintuitive, but legal blindness can be determined in two ways. Yes, your visual acuity, you can't see the E on in the office, the big E, but you could see 20/20 vision when you look at the chart. But if you have lost more than 20, if you're down to less than 20% of peripheral vision, you're also legally blind. So it can be very subtle. So yes, peripheral vision is checked. We check the intraocular pressure. Now, most normal pressure is usually between 12 and 21, even though we know you can have glaucoma at even less than 21. So the peripheral vision intraocular pressure is also checked. Your central corneal thickness. How thick is your cornea? There are some patients who have a very thick cornea, and they can tolerate a much higher pressure. There are other patients who have a very thin cornea, and their pressure is not, they don't tolerate very well, very high pressures at all. So an 18 or 17 may be too high for them. So yes, the central corneal thickness have to be checked. And then of course, we want to take a look at the optic nerve, because the damage really occurs in the optic nerve. That high pressure begins to kill those nerve cells. There's over 2 million nerve cells in the optic nerve, and you could lose quite a bit of them and still have fairly good vision. But yes, you want to take a look at them. You want to take a picture of it. And then periodically, even if you don't have glaucoma, now you have a baseline. And from year to year, you can compare them and you can make a decision whether this person is progressing or whether this person has developed glaucoma. So they may not complain of symptoms. As the disease advances, you may hear that, I don't like driving at night, or, people are sneaking up on me. Out of a sudden, I'm driving out of nowhere. These kids just jump in front of me. And I don't know, I've had a couple of accidents recently. So they may be losing very subtle peripheral vision. So all of those parameters are checked, and the diagnosis is based on all of them, put them all together. But the history is so important.
Excellent.
Scott.
So Dr. Scott, you talked before about there being an imbalance of the production of the fluid and the removal of the fluid. And so does that mean that if the volume within the eyeball increases, then the pressure increases?
Yes, it does. Yes, it does. So, and the most treatment for glaucoma involves medication that either increases the exit of the fluid out or to lower the amount of fluid that's being made. So that control of fluid going out is what makes the difference in your pressure.
Dr. Court,
do we know what causes the imbalance to occur?
Well, that's the $1 million question, but somehow there's an area called the trabecular meshwork. I don't know if you guys remember that from anatomy, but the drainage area, that's where the fluid actually drains out, but the drainage becomes very inefficient. Why? We're still trying to figure that out. But there are some medications that help to increase the exit, and the treatment would be increasing the exit or decreasing the amount of fluid being made. Diamox, acetazolamide, that's another medication that lowers the amount of fluid that's being made. But there's other medication that can tighten the drainage area, including use a laser to tighten it up. And I don't know if you want to get onto the stop, but even cannabis It does have an effect in increasing the drainage area, but those are what we use to treat it. Drainage, increase the drainage or decrease the production of fluid.
And when you say cannabis, you're not talking about the active form that gets you, you're talking which
the THC. Let me go on that a little bit because it's such a common question when you talk about glaucoma. I think back in the 70s, it was found out that there's a few people after they smoke marijuana, it was noted that their glaucoma actually, the pressure went down. So since then, a lot of very notable organizations, institutions have done research on cannabis. And since the legalization, it's become very popular and a lot of people are asking the questions. A lot of research is being done, even by the NIH. And what they found was that smoking marijuana can lower the pressure, but it lowers it for about 3 hours. So the effect is quite short. It's only about 3 hours. To treat glaucoma, you got to cover your optic nerve for 24 hours. And it seems you would have to take in about maybe 8 to 10 cigarettes a day. Of course, the side effects of THC, while it may sound cute to be smoking marijuana, but to have that effect for 24 hours and 24/7, that will not be a reality. So the answer is yes, it does help to lower the pressure, but practicality is not being used because of its side effects of mood altering, mentation, and most of the patient being elderly. So it's one of the ways that the pressure can go down, but it's not advised because even when they put it in drop form, it was not as effective.
Right.
And the CBD form of it is not as effective. So it's the THC that lowers the pressure.
Yeah, I'm glad you cleared that up, that it only lasts for 3 hours. And it's just definitely that's important for us physicians to know, as well as the public itself. Dr. Court, you have a question, please?
Yes, my question to Dr. Scott is, you said that the patients lose their peripheral vision. Well, what symptoms would the patients have that would clue them to say, look, I got to go to see an ophthalmologist because something is wrong? What would they normally present with? And in addition, in terms of loss of central vision, how would they present to the doctor?
Most of the time, very important question, because most of the time when they present, there are no symptoms, absolutely no symptoms. As the disease advances, then the patient may complain, my eyes just don't feel right. I don't like driving at night. I don't see well at night. My vision seems to be getting blurry. I'm changing my glasses too often. They may not have any symptoms. By the time they notice that they're losing peripheral vision, it's too late because that loss of peripheral vision is permanent. So most times patients will not have any symptoms. What's unfortunate is sometimes you will start a patient on medication. The medications can be expensive. Sometimes they have side effects. They burn. They sometimes make your eyes red, and they'll stop taking the medication. And you know what happens? They stop taking the medication for a week. Nothing happens. They haven't seen any difference. They stop it for a month. Nothing happens. Then you don't see them for a couple of years, and they come back and they'll tell you, doc, I've been having a couple of accidents recently, and last week, I ran through a traffic light because the peripheral vision on top has been lost. So by the time they start to notice that they're having a problem, a lot of times it's too late because that vision that's lost is permanent. So it behooves you to come in early, get your eyes checked, and be told nothing is wrong with you. Fine. But if you have a family history, you make sure you come every year and have it checked.
So the key is to have the pressure check in your eyes.
Yes, have a good workup, have a baseline workup, and maybe every year, sometimes every 2 years, recheck it, because unfortunately, no symptoms early in the disease. It's called the sneak thief of sight.
How about loss of central vision?
That's late. That is late. So the peripheral vision goes first, and the central vision goes late. So if you're losing central vision early in the disease process, it may not be glaucoma. There may be other issues involved, or it can be a combination of both. You could have glaucoma, you could have other diseases involved, including macular degeneration and cataracts.
How does loss of central vision present? What do patient complains of?
Reading. The most common is reading. I can't see the small print. It seems like I'm missing something in the middle of the page. I have to move the page to see things clearly. I am driving and I can see my periphery, but I'm missing things in the middle. I have to keep moving my eyes around to see because the central vision is missing. But reading is the most common. It's your macula is used to read, and anything affected your macula, your central vision, you're gonna pick that up pretty soon.
Yeah.
Okay.
Number one, when we began the show, I forgot to just remind everybody that yes, you can type your medical question in, and please do not be hesitant or be scared to type or think we won't answer. Type your medical question in because we're so eager to answer them. And saying that, there's a question Dr. Scott, is glaucoma reversible with diet or medication?
Okay, whatever vision you have lost, unfortunately, it's not reversible. Diet and medication can stop it in its tracks and prevent you from getting any additional loss. Just like when you have hypertension, you take a pill every day to keep your pressure to a certain level and prevent you from going on to any other disease or any additional loss from having a stroke or a heart attack. The drops you put in the eye will control your pressure and prevent you from losing or disease progressing. But no, it cannot reverse the process. The sight that is lost is permanent.
Right.
But Winston, the vision that you lose, you can't restore that, but you can keep the pressure normal. So if the pressure is regulated before you have visual loss, it might prevent you from having visual loss. But once you've lost any amount of vision, it doesn't return.
That's exactly it. Early diagnosis and treatment is the key. Early diagnosis and treatment, and history is just so important. Family history is crucial. You know, in the old folks never used to tell us what was wrong with them. You know, you're young folks, you don't want to hear big people's business. Now we realize it's very important to know what's wrong with them because genetics is so important. So we need to share this information with our family.
Yeah, especially since looking around the panel, everybody except Dr. Daniels is old.
True.
I went to the eye doctor and he said that I had an issue with dry eye. Yes. And that in the mornings when I wake up, it may affect my vision because of the dry eye. Could you spend a minute talking about dry eyes?
Yes, when we make tears, our eyes make tears to lubricate our eyes. And as part of our refractive system, the cornea, the lens, everything refracts light for you to see well. But that tear film is very important. It's part of the refractive system. And the tear film is not just water. It really is made up of 3 layers. You have water in the middle, you have a little oily substance on one side, and you have a little mucinous substance on the other side. So it's almost like a sandwich. And you have to have them in good proportion to make your eyes see very well. Now, as we age, sometimes we lose some of that mucinous part of that sandwich, or sometimes we lose some of that oily part of the sandwich. And your body tries to make up for it by making a lot more tears, but it only makes a lot of water part. So if you don't have enough lubrication in your eyes will be considered dry. Now we live in a technological age where we're constantly on our screens. And the more you concentrate, just think of yourself, the more you concentrate looking at the screen, What you're not doing is you're not blinking like you normally do. That concentration, and the more you concentrate, you blink less, the eyes tend to dry out even more. Blinking is like cleaning the windshield. It really re-wets the surface and it moves everything, any debris from off of it, but it adds more moisture. So as you age, if you don't have enough of that right proportion of tears, your eyes will be considered dry. Sometimes you're not taking enough oil into your diet. You can, if you're not drinking enough fluid into your diet, it can be dry. We are on the screen at all times, especially at work. And when you go home and you go to bed at night, what's the last thing you do? You're on your phone. And the more you concentrate on the phone, the less you blink. So sometimes it's simple, try to force yourself to blink a little bit more. There are a lot of moisturizers, very common things you can buy over the counter. Refresh, Sustain, these are some of the common drops that you can use to help to lubricate your eyes. And if that doesn't work, then there are more prescribed medication. You've seen them advertised, Zydra, Restasis, some of these medications that help your lacrimal gland to produce better tears.
Excellent.
You know, my doctor told me to get an iPad pad that has beads in it that you microwave for 30 seconds. Keep it on the eye for 8 minutes, and it increases the flow.
Yeah, the heat does help to stimulate the glands to produce more tears. And what's helpful for you? Because what helps one person doesn't necessarily help the others. And in fact, when you go to the pharmacy, you'll see about 10 different eye drops, because not any one helps everybody. Sometimes it's a trial and error, and sometimes it helps. But force yourself to blink a little bit more, stare off to the side a little bit more, and come back to the screen, and just add a little moisturizer to your eye from time to time. That's very helpful.
Right. I just Dr. Daniels, I have a question for you, but before I get to that, I want to go back to glaucoma just a little bit. That question had asked about food, different foods. Now, with glaucoma, can that help in eating different foods, or will different foods cause glaucoma? I think it was. And also, we know that prednisone, and from a pulmonary standpoint, I use prednisone all the time with either asthma or bronchitis or inflammatory, to decrease the inflammation in the airways. So I'm very cognizant of the eyes when we're talking about that. But what about different foods? Will different foods affect that at all?
Well, from a standpoint of causing glaucoma, not so much. And we're still doing a lot of research on glaucoma and causes, but not so much that as a causative factor, but definitely as health for the eyes. First, exercise. Just good exercise, and you don't have to strain yourself, just walking. Good aerobics will help your eyes, help oxygenation. But foods that are good with antioxidants are very helpful. Nice leafy green vegetables, nice bright color vegetables, yellow color vegetables, carrots. You know, they used to tell you eat a lot of carrots is good for the eyes. Yes, it is. It is. Leafy green squash, those bright colored fruits do have a lot of xanthine and lutein in it. They're very good. Zinc, all of those help. They're very helpful to the eye. They're protective of the eye. So yes, diet, a good diet is helpful. And of course, the ones that everyone tells you not to eat, the fried foods, these saturated fats, they're same thing. They're not good for your eyes.
Not good, huh?
Yeah.
What about vitamin A? Somebody was saying that vitamin A, have you heard that to be related to?
Yes. But I would just tell someone to take a good multivite, because you can start chasing them with vitamins and you'll end up with a handful of vitamins and you may not even see the increased effect of it. So good multivite, and vitamin D, take your vitamin D, of course, and vitamin C. Yes.
All righty. Dr. Daniels, there's a question that had come in earlier that's not up on our board about a patient that had a tumor in their, I don't know if it was the pituitary area, but a benign tumor that affected their optic chiasm, and they lost their sight. can you give us some indication of where our sight comes from as far as the brain is concerned, what part of it, how it gets to the eye, and the nerves, how they innervate, and if there are tumors that may affect what, our vision, because it's so important and what we need to do?
All right, yeah, this is going to entail a little bit of anatomy. Dr. Scott went over a lot of the anatomy as it pertains to the eye. And so from a neurosurgical perspective, you can look at the eye as a receptor, right? A organ that takes in light and then ultimately sends that signal to the brain so that we can process that light, make sense of that light as it pertains to our surroundings, right? But the brain's really unique. We have two eyes. So in order to process this visual information, it's not like a camera, right? We want to have binocular processing. We want to process two eyes in two different places in time with two different relationships with our body parts. And we do so in a three-dimensional fashion. So that requires a tremendous amount of processing ability. So once we collect information from light into the eyes, it goes back into the optic nerve. And then those optic nerve merged at an area called the optic chiasm, right? A chiasm meaning an area of division. And then some of that information goes to one side of the brain, some of the information goes to the other side of the brain, and each eye provides information to both sides of the brain, right? Where that information is processed in multiple different locations, right? In multiple different other process centers in the brain, right? It's the reason why vision affects balance, right? Because there's parts of the brain that process visual information, and then it also process what's called proprioceptive information from our inner eye. Now, when at the point where these two optic nerves emerge and essentially trade signal pathways to send information to both sides of the brain, right below that is something called your pituitary gland. It's called your master gland, right? It is a gland in the brain that's actually fed by another part of the brain called the hypothalamus. And it then, the hypothalamus samples the bloodstream and the electrolytes and other chemicals in the brain, and then sends a signal to the pituitary gland, which is a gland that creates a chemical that goes to other glands in the body in order to make those secrete substances, like the adrenal gland secretes steroids as a result of substances that are released by the pituitary gland, right? So there's this mechanism in order where the brain can sample our bloodstream and then decide how to alter the chemical balance in our body. And this is controlled by the pituitary gland that sits right below this optic chiasm, this information highway for visual input, visual information. So if you have a tumor that is benign, meaning there's a collection of cells that are growing, but they're not inclined to travel to other parts of the body and be seated in other parts of the body, which makes it really, really dangerous. These cells only grow in the space where they're located. But because there's not much space, and this is really valuable real estate, a growth in those cells can cause compression on the optic chiasm. And because of the way this information is arranged, when that happens, you tend to have loss of vision in your peripheral vision on either side. And so there's a narrowing of the vision that oftentimes people do not notice, but people begin to run into things in their peripheral vision where they normally would see where they don't see it, right? And that's one of the first things that leads to people being aware that they might be having visual problems in their peripheral vision. So although it's a benign tumor, depending on the nature of that tumor, depending on the type of pituitary tumor it is, there could be medication that you can use to shrink the pituitary tumor. Those are typically prolactinomas, tumors that produce prolactin, tumors that are created from cells that produce prolactin, which actually respond to medication. But oftentimes, these are tumors that don't respond to medication, and they require either a surgical intervention, removing some of the tumor. We do it through a procedure through the nose, or radiation to shrink down the size of the tumor. Of note, the optic chiasm and the optic nerves are exquisitely sensitive to radiation. So tumor is, depending on the size of the tumor and its relationship to the optic apparatus, including the optic chiasm, a more direct surgical decompression is usually warranted.
Excellent, excellent. What part of the brain really allows us to see?
like I said, there's many parts of the brain.
Many part. Oh, okay.
So traditionally, we would say the occipital lobes.
Right? That lobe. Okay.
But that's what you're really dealing with occipital lobes is more higher processing. This is important for me as a surgeon because I can do a surgery on the temporal lobe that might affect something called Meyer's loops, which are pathways that go from the optic nerve to the other parts of the brain, the superior colliculus and or the occipital lobes. So though I might be operating far near away from the occipital lobes, but I might injure the vision in a way to where you'll cause a visual field deficit. Mm-hmm. So although you can go online and you can look, the parts of the brain that are in the back, which are occipital lobes, those are the parts of the cortex that are responsible for processing higher visual function. But visual function actually takes place in multiple parts of the brain, and multiple parts of the brain can impact someone's vision. And we're not talking about, the brain is so sophisticated, we're not talking about a camera where you take in visual information and then you get another picture. We use vision for so much more than that, right? There's a phenomenon called blind sight. It's actually one of the things that got me interested in neurosurgery, where people lose the perception of vision, so they don't think they can see, right? But if you put them in a room where there are objects and they're not thinking about it, they'll walk around those objects. And you think to themselves, well, maybe they have another sense that prevents them from hitting these objects. Well, you turn off the lights, they'll hit everything in their way, right? So this concept of vision, as we interpret it, more publicly, it's far more sophisticated when it's taking place in the brain.
Yeah, the thing of it is, in looking at it from a critical care point of view, I see strokes so often. And even though the stroke or is not in that occipital lobe, some people still have vision problems. And you're talking about the nerves that travel throughout the brain in its different aspects. That it makes it more understandable now. Yeah. Mm-hmm. Anyone else chime in on this? This is so important and so interesting. Yes.
Dr. Daniels, I know that some of the tumors in children can affect vision, and it's not always something that parents do, is take their children to see a pediatric ophthalmologist. How might that tumor manifest or affect vision in children, and what might parents do to try and figure that something's going wrong?
Good question. So one, if you have a tumor sitting and destroying parts of the brain that are along that pathway where the visual signal travels, then you can get abnormalities in vision. Children, it's tough because kids tend to compensate, right? They tend to kind of just keep it moving. And depending on their age, they may not necessarily have the vocabulary or the understanding to let you know how they're feeling. They might get along and function in ways where you would never know it, right? Now, there are more global injuries to the optic apparatus that can occur with tumors. If you have tumors that are blocking the natural flow of fluid or contributing to an increase in pressure in the brain, after a child's 2.5 years of age, their skull becomes fixed, it's fused. And that's because the brain's stopped the most rapid period of growth. By the time a child's 2.5 years of age, its brain is 80% the size of an adult brain. It's the reason why kids' heads are so big, proportional to everything else. So once that rapid growth phase has stopped, then the skull can behave more like an adult skull behaves. And it's one shell of bone that continues to grow, but it grows through a much slower process. But as a result of that, if you get an accumulation of additional mass inside the cranial vault, inside the skull, that mass will be translated into an increase in pressure. And one way that I use to determine whether patients are experiencing increased pressure or not is I'll send the kids to an ophthalmologist. Because the fluid that surrounds the brain also enters the optic sheath, which is the covering of the optic nerve, you can manifest an increase in pressure in the optic nerve by looking in someone's eye, right? And looking at their retina and looking at the blood vessels that surround the retina, and can give you an idea whether they have something called papilledema, which is an indication of increased intracranial pressure. So you might have a child that's experiencing headaches. You might have a child that's experiencing nausea, vomiting, and you've ruled out all other causes. It might be helpful to send that child to an ophthalmologist. or have that pediatrician send the child to an ophthalmologist to look in the eyes and see if they have evidence of increased pressure in their head, which might warrant additional studies like an MRI, CT scan, in some cases, even something called an ICP monitor, where we stick a small monitor in the brain and we measure the pressures to see if there's any pathologies that would increase the pressure in the head. And this is important because patients with chronic increase in cranial pressure, they can lose their vision because of the pressure in the part of the eye that's responsible for gathering that information, the visual.
Could you just say just a little bit about the difference in the vomiting you might see with intracranial pressure issues versus gastrointestinal issues?
It would say that, oh, the vomiting. Yeah, sometimes it's hard to determine really on pediatric patients. But if you have patients that are, all right, so there's a part of the brain called the area postrema. And it's a part of the brain that begins to be infected and impacted when you have increased pressure. So it's the mechanical pressure on that part of the brain that gives the sensation of nausea and that makes someone throw up. It's very different than someone who might have GI issues. So when you stimulate their gut by eating certain things or eating anything, they feel the need to vomit after that. This need to vomit is something that's being controlled by the brain. So you'll get something called dry heaving, meaning you'll get people who vomit, but nothing comes out, or they'll vomit well after they've eaten, or they'll vomit bilious substance, which is essentially the substance that's in the stomach that we don't put in there, that occurs in your gastrointestinal region without any input. So the act of vomiting without stimulation from feeding or eating, or vomiting even when someone's stomach's empty, could be a sign that you're getting vomiting from irritation in the brain. So central nausea versus it being caused by something that's irritating your GI system.
Excellent. You know, something you said just popped into my head, my own child, and understand this is it's interesting because both my wife and I are physicians and she's a pediatrician. And when you said kids just get along and they just, you know, it just doesn't affect them. Well, my own personal, this is a personal to me, my daughter, my wife was at a health fair and you know, while you're at the health fair, my wife was helping with the adolescent stuff and my daughter went around and, you know, go take the kids and test their vision. Well, guess what? My daughter's one eye was not seeing well. And we as physicians didn't recognize it because she never complained. And, you know, so just to let you know and let others know that you have to be cognizant and really get your children checked out as far as vision is concerned, because they may not be complaining, but there may be a problem.
Yes,
I just want to say something about that. That's really important.
All right, Kendall, hold on. And it'll be Kendall, then it'll be Dr. Scott, then it's Dr. Daniels. Okay, we're going to go in that order. Go ahead.
Because you talked about not having seen in one eye, you know, and we have both eyes seeing. And for some children, they're cross-eyed. They call it strabismus, where because the eyes are crossed, they have double vision, which the brain doesn't tolerate. And so what will often happen is that they may suppress the vision in one eye, and that part of the brain that receives that information doesn't develop. And if it doesn't develop over a certain period of time, it will never develop. So that's why it's important that if you have a child who's cross-eyed or that has strabismus, for them to be seen by an ophthalmologist, especially one who deals with the children, so that they can make the diagnosis. And if they do the corrective surgery, can prevent them from having that blindness, not related to the mechanics, but just related to that portion of the brain that doesn't develop because it didn't have the kind of input.
Yes, and Ken, you know, that's so important what you just mentioned there. In fact, before the child goes to kindergarten, they really should have a full examination where both eyes are fully examined. Because if it's not done, the child will never tell you. As far as they're concerned, that's how everybody else sees. And they would think that's how the world is supposed to be. So you do have to catch them before they start kindergarten and do a really thorough examination. And the other point I wanted to make, Ken, as we were talking about tumors, is mom need to know that if you look into the pupil of your young child, And if they don't look the same, make sure they go and see an ophthalmologist for thorough examination, especially if one of the pupils tend to look a little bit white. There is something called a leukocoria. And a leukocoria could be something as serious as a retinoblastoma, which is a very serious tumor, or it could be some exudation in the back of the eye for some kind of Coats disease or diseases that can cause severe damage to the vasculature, or it could be congenital cataract. So look into the eyes. If the pupil do not look the same, definitely have that child be thoroughly checked out. And especially if it looks a little bit white in one of the eyes, absolutely needs to be checked out immediately.
All righty.
You know, and just to that point, you know, given the days of these time visits, where the examinations and the histories are shortened, I'm not sure that the pediatricians will often give the eye the kind of thorough examination that they should get. So that sometimes the parents may be a lot more observant and pick up things that the pediatrician ought to, but may not. So it is important for people to look at those things, and if they have a question, to call it to the attention of the pediatrician, and then they may spend more time looking and then make the determination. Then they'll make the referral to the ophthalmologist.
All righty. Dr. Anderson.
Hi, everybody. I apologize for being late, but Dr. Scott and Dr. Daniels kind of summarizes some of the issues I have on the adult side of things with respect to tumors, where, you know, all of a sudden a patient start having issues with orientation as it relates to space, issues with nausea, vomiting, as Dr. Daniels mentioned, issues with double vision or loss of vision in one eye, which is oftentimes rare in adult oncology, or tumor, where you have metastatic disease to the brain, intracranial pressure gets increased, and they become nauseous all the time with this dry heaves that Dr. Daniels so well summarized. But a rare instance 2 years ago was a young patient with a vulvar cancer who developed loss of vision in the left eye. And the ophthalmologist comes along and looked at her and says, she has metastatic disease in the eye. Can you both comment on that, things to look for? It's albeit rare, but I was astonished. I still have photograph of the retina with the tumor in the back of the eye.
Yeah, this is something where if you don't look for it, you're not going to find it. And you really need to go to a thorough, dilated exam where you can look at all aspects of the retina and the choroid, which is very vascular. It tends to metastasize to the choroid underneath the retina. And without looking, you're not going to find it. The patient may have very subtle signs. Depends on which type of eye doctor you go to. You may not, it may not be diagnosed. I mean, you know, just as I may speak about eye doctors in general, most patients will go to an optician or an optometrist to get their eyes examined, and they will be sold glasses or contact lens and have a very small cursory examination. Someone like that really needs to go to an ophthalmologist who's going to give them a much more thorough examination. And if the ophthalmology suspicion is high and he can't find it, he may send her to a retinal doctor who can go even more, a deeper examination. But something like that, you will not find it unless you look thoroughly for it. But the history is important. The history can lead you to where to look.
Excellent.
Yeah, and my perspective, what I wanted to add, you know, children are generally really, really healthy, right? And most of the disease processes that most individuals in our country are afflicted with take some time, right? But it's important for the parents to have their children be seen, because it's these type of things that are not obvious, that are not overt, that requires experts to screen children for, that are picked up. And the earlier we pick these things up, especially with children, the greater we have an opportunity to intervene in a manner where we can deal with it, we can cure it. So having your children see the pediatricians and get these full exams once a year becomes really, really, really important.
Dr. Anderson.
This one is for Dr. Scott. At a time when everyone talks about disparity in outcomes in healthcare, excuse me, are there things that are unique to the African American population that should require us getting more thorough, more frequent ophthalmologic evaluation? One of the things that come to mind is a colleague of mine used to talk about cupping, and what does that mean, and how is that different in the African American community, and the implication of that?
Yeah, that's usually referred to glaucoma, and glaucoma is the #1 cause of blindness in Black people, and the number one cause of irreversible blindness in the entire world. Glaucoma is cataracts is the #1 cause of blindness in the whole worldwide. But cataracts is a reversible form of a disease that can be cured by having surgery. But glaucoma is the #1 cause of irreversible blindness in Black patients. And when compared to our white counterparts, we contract this disease 5 times as much. And when we get it at a much earlier age, and it's more difficult to treat. Why? We're not sure. A lot of work is being done, but there is some genetic predisposition to put us at this risk and this complication of taking care of it. Very often you may see someone diagnosed with glaucoma and one medication may be all in your white colleague, and they may do fine. The Black patient, 2, sometimes 3 medications, surgery, laser surgery to keep them under control. So when we do get it, it tends to be more problematic, more difficult to treat. So if there's a family history of glaucoma, you want to get an early diagnosis. Before we used to tell them before 50. Then we used to say before 40. Now 35, if there's a family history, get a baseline examination. Check the optic nerve, take pictures of the nerve for that cupping. How much of that cupping is there? Usually in the cupping, you're referring to how much ganglion cells have actually been lost. How much of that cell has died. And the more died, the larger the cup. So you want to make a picture of that. You want to check their peripheral vision first. You want to check a baseline intraocular pressure. You want to check how thick is their cornea, the central corneal thickness, and you keep that as a baseline. And every year you check it. If there's no family history, maybe you could go 2 years. But definitely with the family history, you want to get them in there at least once a year. And then you add on top of it, those who have hypertension, another risk factor. Those who have diabetes, another risk factor. The more of those risk factors, the more you have to hold them closer and examine them more. Trauma as a child, you're in a fight, you got punched in the eye when you're a kid. Big deal, you got a black eye, and after a couple of weeks, it got away. But later on in life, that little damage to that trabecular meshwork can put you at further risk for glaucoma. The kid who's been on steroids, whether it's the asthma pump or the acute treatment for the swelling of the knee, and every time they have a knee problem, they go to the prednisone. You keep that as a risk factor. And just being Black puts us at risk. So we do have to keep a closer eye on those patients.
All righty, guys, let me do this. Hold your questions. I know that we have a lot of hands up, and I want to let everybody have time. After we get finished with Dr. Salam and Dr. Court, I want to go to questions because we have about 5 or 6 questions that we have to handle before the program is over as well. And I know more will be coming in. I'd like to say, and this is our halftime, so let me say thumbs up to our Facebook crowd. I'm looking at it and our Facebook is booming up there nicely, and give us a thumbs up on the Facebook side. What I'd also like to do is let us introduce ourselves. Some of you had come in and I didn't get a chance to let you introduce. Let's introduce now. Dr. Patrick Anderson, please.
Hi, everyone. It's always an honor to be here with this distinguished group. Dr. Scott, welcome. I see my professor, Dr. Spratt. I'm a G1 oncologist, chief at Newark Beth Israel Medical Center, where I do most of my work.
Thank you. Dr. Salam, welcome.
Welcome. Good afternoon, audience, and the brothers on the panel. It's an absolute delight to be a part of this distinguished group. My name is Dr. Kareem Salam. I'm a board-certified adult and child and adolescent psychiatrist. I'm the medical director of adolescent services at a hospital in Northeast Philadelphia, and I'm on faculty at Drexel University College of Medicine. And Dr. Scott, welcome. This is a rich and interesting discussion about things ophthalmologic.
Thank you.
All right. Dr. Court, you're on mute. You're on mute.
Absolutely. Dr. James Court, my office is in East Orange, New Jersey. My specialty is internal medicine.
All righty. And Dr. Scott, reintroduce yourself, please.
Yes, my name is Dr. Winston Scott. I'm an ophthalmologist. I'm chief of ophthalmology at Carewell Health Medical Center. That is formerly East Orange General Hospital.
Excellent, excellent. And Dr. Sprott?
Yes, I'm a board certified pediatrician. I did 15 years of pediatric critical care and additional years of general pediatrics.
All right, thank you. Dr. Lawrence Daniels, I don't know, Dr. Daniels may have had to step away just for a minute, so we'll reintroduce him when he comes back. Also, let me say that our webinar is every second Saturday at 1 o'clock. Please let family and friends know. It's all about health and wellness, and it's about health and wellness for people of African descent. So we are here to answer your medical questions. Please note that if you want to see our prior webinars, all you have to do is go to the website OBHealthy and click our YouTube channel. All of the prior webinars are there. Please go check them out. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician, no matter what we say. Only your personal doctor can appropriately treat you from a medical standpoint. I would like to thank OBHealthy for allowing us to use their platform so that we can bring this webinar to you. Thank you, thank you, thank you. Okay, so number one, I'm Dr. Omar Bey, and I'm a pulmonary critical care physician with a subspecialty in nutrition. I seem to always forget to introduce myself. All righty, let's just go back and start over again. Dr. Salam, you're up.
So, Dr. Scott, your response or your comments to the last question really touched on the questions that I had, but I wanted to see if I could get you to speak about mechanism if possible. You mentioned the link between hypertension, or you've identified hypertension as a risk factor for glaucoma. So I wanted to know, are there any thoughts on how that's mediated? In addition to being Black. So there's this concept called weathering that was described by a researcher at the University of Michigan named Arlene Geronimus, who was not Black, but noticed that African Americans suffer a disproportionate number of medical conditions at an earlier age. And her thesis was that this is a function of being Black, just the ubiquitous nature of racism and how it actually ages us at a cellular level. In the 80s, when she gave rise to this theory, it was very unpopular in both white camps and Black camps. But now it's being revisited, and the literature on this is vast. And there's a book entitled Weathering by Dr. Arlene Geronimus. But Dr. Scott, I wanted to know if you had any thoughts on the connection or the way the effects of being Black, how that's mediated on the eye and how it may contribute to visual problems like glaucoma. Had any thoughts on that? And is it mediated through the hypothalamic pituitary adrenal axis? Any thoughts on that?
Yeah, I think you hit on something there, because, you know, we've always thought, and I know my father used to discuss this, that when you're Black in this country, you pay an extra tax. And unfortunately, that tax can be physiologic. And that stress of just being Blacks from surviving in this society, we release more cortisol, which can also cause our blood pressure, our blood sugar to rise, which certainly can affect the eyes. Blood pressure, it's a delicate balance when it comes to the eyes, especially someone who has glaucoma. Yes, you want to make sure it's not too high and controlling the blood pressure. But if at the same time, if you overtreat it and drop the blood pressure too low, you decrease the blood flow to the eye and can also make the glaucoma worse. But again, to your point, you talk about the connection to racism and the stress. That extra tax that we pay is physiological in the form of stress, increased blood pressure, increased blood sugar, and yes, and of course, you know, that affects every part of our body.
Yes, definitely. Dr. Court, yeah, I think you were next.
Yes. Okay. Dr. Scott, in reference to treatment of glaucoma, when is surgery indicated and or laser treatment?
All right, so the first line of treatment is usually an eye drop. And the prostaglandin-related eye drops, you see the names, Lumagan, Zolatan, latanoprost. Those are probably our most effective drops. So those are usually the very first line way of treatment. One drop every night before you go to bed. That is very effective. We spoke earlier about the effectiveness of cannabis, which can also lower the pressure, but you need it. It only works for about 3 hours, which means about every 3 hours you have to replenish it. So the prostaglandin is usually our first line of treatment, one drop every night before you go to bed. Now, if that doesn't work, our next line of treatment, we add additional medications. Now, some patients don't want medications at all, in which case you can start them off with a laser treatment, which can treat the trabecular meshwork to slightly open up the drainage area to lower the pressure. And that seems to stay in effect for a good year, sometimes 2 years in some people. So that's the second line of treatment that sometimes can be used as a first line. Now, if medications are working, if the laser is working, we usually leave that alone. However, in some patients, neither one is working or neither one is effective. They're taking their medication, they're being very compliant, but they're continuing to lose visual field. The optic nerve tissue is beginning to, there's increased cupping despite all of these medications. Then in which case you have to do a surgical procedure to try and lower the pressure. And when you do a surgical procedure, you actually try to create like a little area where the fluid can go out. If the drainage area by itself is not working, you have to help it to create an additional area for the fluid to go out. So you try to leave surgery until you have tried the other steps first. Drops, and sometimes not even one drop, 2 drops, 2 different drops, and laser first before you go to surgery. You know, surgery, like everything else, once you cut people of color, very often we tend to scar easily. The eye's no different. Sometimes it scars down and it spoils the surgery. The surgery might work for a few months, and then we tend to heal ourselves a little bit too well. And we get scar tissue, and sometimes the surgery don't work.
How do you treat acute angle closure glaucoma? Is surgery indicated?
Yes. And the surgery, though, can be done right in the office. You can use a laser. Usually in acute angle closure glaucoma, the drainage area, the angle where fluid drains out is too narrow, and the fluid is not going out. It's backing up into the eye, and it stays in the behind the iris. By simply using a laser to open a hole called a peritomy in the iris, you can let the fluid come into the anterior chamber, which will also help to open up the angle even wider. So you can actually treat it, and in some cases you can cure it by using a laser to create an opening in the iris and further open up the iris, open up the angle.
Excellent, excellent. I think Dr. Sprout was next, and then we'll have Dr. Anderson and then Dr. Salam. Go ahead.
Yeah, for Dr. Daniels and Dr. Scott, what's the issue with individuals that have traumatic brain injury or trauma to the brain that can lead to cortical blindness or blindness associated with the brain, not with the eye or the apparatus to the brain?
Well, I'm going to leave most of that to my colleague, my neurosurgeon colleague. But of course, the occipital region of the brain, a lot of the fibers to the eyes go back to that area. So of course, depending on where the trauma is, especially into the occipital area, it could cause you to lose your sight. But I'll let him expound on it.
Yeah, look, it's you know, the way the brain works is there are electrical signals that pass along trillions of cells that interconnect, that ultimately give rise to what we call higher cortical function, right? The things that, you know, we appreciate, you know, as human beings, like vision and sight and memory and emotions and all these complex things. And a simple way to look at it is that this part of the brain controls this and this part of the brain controls that, but that's not really the case. It is a orchestrated passage of information by way of electrical signals from one path to a next at the speed of light almost, right? That ultimately yields some of these complex behaviors. So when you have someone that's experienced so much force, like a car accident or a fall from a tremendous height, even though on the imaging studies, we may not look and see that the MRI shows that there's damage in that part of the brain, people can manifest with symptoms that are located in multiple different parts of the brain and that manifests in many different ways. So there's a spectrum, right, that we refer to between people who might have a concussion, right, which is you have a CT scan or an MRI, it doesn't show evidence of damage or trauma to your brain, but you have symptoms. A lot of times it could just be a headache, or it could be sensitivity to other sensations or even information, or it could be exhibiting symptoms like headaches or irritation or nausea, vomiting when you exert your brain, which might be as simple as doing your homework or reading, right? Or going to work, some type of cognitive activity that increases the activity in your brain that's healing. In the same way where if you sprain your ankle and you tried to play basketball on it, it would hurt and it would swell up and it would not work as well, right? But on the opposite end of that spectrum, we have something called diffuse axonal injury, right? Which again, you don't have evidence of a particular part of your brain being injured or destroyed, but there's evidence that multiple different parts of your brain, specifically the parts of the brain where these pathways search from one area to the next, have been disturbed. And it's a more global insult, and it can lead to some of these more higher order symptoms. And that can range from inability to move, not speaking well, not understanding things as well, changes in your mood and behavior, and visual symptoms as well. Anything that the brain does can be impacted by injuries like that, these more global injuries that affects the entire brain and how different parts of the brain interact.
I know you can't answer, but could that be what's going on with Senator McConnell when he freezes up?
No, I think he's having absent seizures.
I think the same thing, but no one's mentioned absent seizures.
You know how it is.
Yeah, but how do we know this is not a vascular issue? You know, one of the fascinating things to me with respect to the brain and the eye is how the brain can have a circle of Willis, which is a network of vessels that if one side gets obstructed, the blood gets rerouted the other way. But the eye is one of those classic organs with an end organ vessel. That fascinates me. Can we talk about how injuries, things like thromboembolic or blood clotting issues can affect the brain overall and the eye in general?
Or even strokes causing visual issues.
Right.
So I'll tell you really quickly, the reason why we know it's not a vascular entity, meaning it's not a blood vessel and you know, we categorize these blood vessels to the proximity of the neck, because everything comes from essentially, you know, 3 arteries, your carotid arteries in the front. These are the arteries where if you feel with your fingers, you can feel the pulsation, and then one in the back you can't feel. It's called the basilar artery. Those arteries come up together and form what Dr. Anderson referred to as something called a circle of Willis, which is a redundancy of supply to the brain.
Right.
So that if one of those arteries is shut off in a certain way, you might be able to, this is less likely with older people than it is with younger people.
Right.
You might be able to draw blood from some of those redundant connections. Now, when you then therefore have an absence of brain activity from one of those arteries stopping, it typically covers a territory, right? So it's not something as global as you think about this, you being able to respond to someone talking to you and then fix your lips, your mouth, your body to then respond back to them. That's what's called higher cortical function. That's located in multiple different parts of the brain. Mm-hmm. So typically when you have someone who exhibits a loss of function on the level that, you know, the head of the Republican Party of the Senate did, Mitch McConnell, it typically involves a more global insult. And so then you start talking about how do these two parts of the brain connect? And then what does that look like when they're malfunctioning? So to get one part of the brain that's not functioning, another part of the brain not functioning, which is typically what's happening in an absence seizure, you have electrical activity traveling from one area to the next. That's why it's more easy to explain it from that phenomenon to another. The question is it related to the trauma that he experienced? And that's the explanation they're giving. I don't know. Right? It could also be related to something else going on that we may never learn about.
But dehydration doesn't seem likely to me.
Well, dehydration can lead to concentrations. Okay, so
I understand, but he didn't appear to be suffering from dehydration.
Something's going on.
All right. We're gonna cap that right now.
Right.
Dr. Anderson, you were up with
yes, and I got sidetracked because you know these two gentlemen on the screen next to each other, you know, from an anatomic perspective, how the eye and the brain function in so many ways. You know, I use proprioception, your orientation in space, I think it's just a fantastic combination. And for me as a surgeon who now doing robotic surgery and has to now add depth of perception to all that stuff, it's just an amazing phenomenon. But anyway, Dr. Scott, what I wanted to ask was from a woman's health perspective, menopause, how does that affect or manifest itself from an ophthalmologic perspective?
The most common is dry eyes, because the hormones does affect how well the lacrimal gland works. And by far, dry eyes is the most common complaint. Once you get into the menopausal range, you know, the eyes don't feel well. I'm not seeing as well because the tear fluid is very important as part of the refractive coupling that allows you to see well. It's not just the cornea, it's not just the lens, but the amount of tears that sits on your eye, on your cornea, is very important for you to see well. And that's probably the most common cause, just dryness to the eye. Dryness to the eyes, dryness to the mouth, and dryness elsewhere.
Mm-hmm. All righty. Dr. Salam. And I'm going to move this along because I really want to get to the 5 questions and I know sometimes we get talking on that quite extensively sometimes. But Dr. Salam, you're up.
So I know I joined the webinar late, so if this was already discussed, we could skip this question. So the first question is, Dr. Scott, could you speak about LASIK, especially for those of us who are middle-aged and we may want to shed these devices that support our vision? Mm-hmm. What are your thoughts on LASIK? That's number 1. And number 2, is there a cluster of sports-related injuries that affect vision and that affect the eye? And I would encourage Dr. Daniels to weigh in as well. But are you seeing that in your practices, especially among young people, sports-related injuries that affect vision or visual function?
Well, I'll begin with the LASIK, and the procedure is getting better and better each year. My wife had it done just probably about 10 years ago. And since she has had it, the procedure has even improved even more. It does allow you, I'm not sure if you're nearsighted or you're farsighted, but especially it's more effective for people who are nearsighted. It will be able to correct your distance vision. Now, that being said, if you're nearsighted, you know, when you take off your glasses, you can read with your naked eyes if you're nearsighted.
Mhm.
Now, when you have LASIK, they have corrected your distance vision, so you're no longer nearsighted. So now when you try to read, you're no longer nearsighted, you're going to be reaching for your reading glasses. So just to keep that in mind. But there are ways that they can make a small imbalance. They can leave a little residual nearsightedness in one eye and make the other eye almost perfect for distance. And you can have somewhat of a mono vision, but it can still work. But most people are just so happy to get rid of their glasses that they don't mind having a pair of little reading glasses they keep in their pocket that they can use whenever they need to. But the procedure does work. It does work well. And some patients, after a while, it wears off. So you may have 20/20 right after the surgery. Sometime 5 years, 6 years down the line, you might find that you regress back to 20/30 or so. But if you started out being very nearsighted, you will still appreciate 20/30 vision without glasses. So yes, the procedure does work, and I do encourage patients who want to have it done. But I also remind them that it is a surgical procedure. So there are complications that can occur. It's not 100% safe, but it's safe enough that I think it's worthwhile making the risk for those of you who really want to have it done.
Could
Now,
you explain what LASIK is?
Oh yes, all right. So LASIK, the word LASIK itself means laser in situ keratomileusis. And what it does is when you're nearsighted, it means your eyes are anatomically too long. And the image comes to focus a little bit before your retina. So what the LASIK does, it actually shrinks your cornea and puts your eyes in the right anatomical length for the light to focus directly on your retina and put the image in the right focus. So you're actually shrinking the eyes down. It changes the curvature of the cornea and shrink it down to a level where it increases your focus. And it works very well. There's some people who may not qualify for it because if your cornea is a little bit thin to begin with, the laser is going to make it even thinner and it may be too thin. So you need to be qualified to say if you are a candidate. And they will check the thickness of your cornea to let you know whether you're a candidate or not. Most people are, but it has to be checked before you have the procedure. Excellent. So LASIK, yes, can correct your distance vision. It can correct your near vision to some effect, but not as effective as people who are nearsighted.
Excellent, excellent. Dr. Court, did you have a question? I know you had your hand up earlier.
It was to proceed to the next topic in terms of pink eyes. If you can expand on the different types. Okay.
Oh yeah.
I'm sure you had that in mind to go this.
Oh yes. So probably the most common cause of.
And we also have some questions in the forum. I kind of building.
Yeah, I know. I really want to get to those questions in the forum.
You want to stay with that?
Yeah, we have questions in the forum that we have to get to that people have put in.
Go ahead.
Let me do your question.
Yeah. So let's do this. Let's go ahead and get some of these questions in the forum taken care of, and then we'll come back. And even if we have to ride over a little bit on the show, that's fine, just so that we can make sure that we cover it all. So this is Ms. Green. What are other symptoms that might appear in the body, such as headaches and neck pain, that could be related to eye disease? Dr. Scott, can we start off with you?
All right, so neck pain, so eye strain, proper posture can affect certainly the neck and can certainly cause problems. Eye strain can also cause your neck pain. Your squinting all the time can cause that. And just strain in general can cause cervical pain. The amount of time you're spending on your tablet, your phone, all of these can relate to strain on your neck.
Excellent, excellent. Dr. Anderson, this question will relate to you. At what age is it safe for a female to discontinue GYN exams, like vaginal exam?
I think that's somewhat of a loaded question. And I think oftentimes what drives that conversation is who's willing to pay for an intervention at an older age. But that should really be individualized. It depends on patient's history. So for example, a patient who has a malignant or a pre-malignant lesion, depending on the duration between diagnosis, treatment, and disease-free interval, that dictates when one can not necessarily stop, but increase the interval between evaluation. Issues with human papillomavirus related issues should be considered. Patients with chronic inflammatory vulvar or perianal issues, such as lichen sclerosis and those kind of skin issues, because albeit less common than a virally related cancer, these also put patients at risk for cancers of the lower genital tract. Patients with a history of gastrointestinal cancers, patients with a history of breast cancer, that can also metastasize to the genital tract. So as far as I'm concerned, there's no time that's our age when it's safe not to do it. I think a pelvic exam should be considered as part of every annual physical exam. Now, it's the yield or what you're most likely to find on those pelvic exams. So for example, patients who've had hysterectomies with removal of the cervix, yes, you may not have to do a pap smear. However, there is additional information that can be acquired by doing a pelvic exam, also when it includes a rectal exam. So as far as I'm concerned, you know, it's my personal bias. I function from a cancer perspective at all times. I don't think there's a time when it's totally safe to exclude it, especially in patients who are very functional.
Excellent, excellent. The next question, and Dr. Atherley is not here, unfortunately. He had a conference to go to. Can heart disease improve? I mean, it's a basic question. Dr. Court, internal medicine, and I know that you do deal with the heart as well as other aspects of the body. Can you help us out? Can heart disease improve?
Well, of course, it will depend on what type of heart disease you have. Is it related to a structure? Is it a valvular? Is it congestive heart failure?
Mm-hmm.
It depends on the type, of course. If it's due to some valvular issue, if you correct that surgically, of course, yes, the patient would get better. If it's due to like heart failure, you take the medications. And more recently, there's been a wonderful drug that's been used, Entresto, that I've seen a few patients who have done very, very well using Entresto for, it doesn't cure it, but certainly they function so much better. And certainly that amounts to some improvement. Again, it depends on what is the etiology of the heart condition before you can really, certainly there's a chance. Yes, it's possible. Yes.
All right, thank you. The next question, is it true that glasses can make your eyes weaker over time? Should you try not to wear your glasses around the house, at home, for a bit of time to reduce this worsening of vision?
Okay, that's a very common question that's being asked. And the answer somewhat depends on how old are you? How old is the patient? So if you are nearsighted and you're a youngster and you're nearsighted, nearsighted means that with the naked eyes, you can see everything good, near. You have good near vision and you can't see from a distance. Farsighted mean that with your naked eyes, you can see very far. But when it comes to reading, you have to hold things further and further away from you. So it depends on how old are you. If you are nearsighted and you want to see very well, it depends on the level of nearsighted, you need to wear your glasses. Now, as a youngster, nearsightedness is somewhat anatomical. as you grow, the eye also grows and you become more and more nearsighted. So it's not because you started wearing glasses, but it's as the child is growing and the eye grows, he or she will need to wear the glasses more. They become more and more nearsighted. Now, when you get to be an adult and you get into that presbyopic age, so right around 40 for some people, if you never had to wear glasses when you were young, and at age 40, you start to notice that now you have to start holding things further and further from you. The things you used to look at and read on the bottle is becoming more and more difficult. It means now you're becoming presbyopic, and you may need to wear reading glasses. Now, you may want to, instead of wearing reading glasses immediately, you may want to see that maybe you can get by just holding things a little further, making sure that the lighting is very good when you read. And when it's very dark, then you put your glasses on. Daytime, when it's nice and bright, use the sunlight. That's the best light for you to see well. Train your eyes to do without it during the daytime. But definitely at night, if you really need to see well, yes, put them on. It's not that the eyes is making you worse, but every birthday, as your birthday cake gets brighter and brighter, you need a little bit stronger glasses. So it doesn't necessarily mean it's the glasses that's causing you to become dependent on it. You need it. But daytime, yes, you can give yourself a break, use the natural sunlight, increase the lighting in your house. In my bedroom, my lighting in my house is very bright because I want to take it as easy on my eyes as possible. And that way I may not become as dependent on my glasses. But as I age, it's part of aging. You need to get
Winston,
a little bit stronger.
You talked about the older individual. What about the younger children?
Yes.
They're wearing the glasses doesn't make their eyes weaker. I think the whole question about what does a weak eye mean, you know, the glasses are designed to improve your ability to see because of the problem with the shape of your cornea. But those glasses don't make your eyes weak. And so you shouldn't wear your eyes less for fear of your eyes coming weak, especially if you're very young and not in the age where your eyes changing.
Yeah. And as they grow, they may need a little bit more and more glasses.
Yeah.
All right, next question. We got some good ones coming up. Hello, I was recently diagnosed with CSC, or central serous chorioretinopathy. And I was wondering what this is and what can I do, what can be done to treat this?
Well, all right, central serous chorioretinopathy is a development of fluid underneath the retina. And you see it very often in that type A personality person, that always person under a lot of stress. And you also see it just idiopathically, it just happens. And sometimes we never find out why a person have it. But most times you can be assured that it'll go away by itself. It's self-treating. Some people, if they think it's stress related, you can see your doctor. They may give you something for anxiety or stress. And as that's related, you may get less and less fluid buildup under the retina, especially if that retina gets into that macular area. It can really be debilitating. But it is something that's self-limited, and most of the time it'll go away on its own. But if you can figure out what is causing stress, if it's in fact stress related, try to take care of that first and it'll go away by itself. It's just like sometimes something a little bit more similar than central serous. But if you look, you'll notice that your eyelid just kind of twitch sometimes. You look in the mirror, you actually kind of see it twitching or you can feel it. It's called facial myokemia. And again, it's something self-limited and usually go away by itself, but usually stress, tension, lack of sleep, fatigue, eye strain, those are the things that tend to cause it. If you can figure out which one of those is causing it, when it goes away, that little twitching of the eyelid will also tend to go away. But it's not something that I worry about, but if it's prolonged, then definitely see a retina specialist. who can do an angiogram and notice exactly how much fluid you have accumulated, and it can be treated. But most of the time, we prefer to leave it alone. Take care of what is really causing it, and just give it enough time to go away by itself.
Doc, is this similar to vitreous detachment?
No, that's slightly different. Now, the vitreous fills the eye cavity, and it's a gelatinous material that is attached to the retina. Just normal aging, that gel begins to shrink. And when it shrinks, it peels itself away from the retina, and now it's called a posterior vitreous detachment. Most of the time it's benign. It causes nothing. You may see like little floaters from time to time, or you may see a little flash of light. If the flashing of the light persists, you need to come in and get a full ophthalmologic examination, because when the vitreous pull itself away from the retina, it can pop one of those little blood vessels in the back and can cause a hemorrhage, or sometimes it can pull on the retina and cause a little tear in the retina. And that can eventually go on to become a retinal detachment. It's not the usual, but especially if you notice a persistent flashing of light, it needs to be investigated a little further.
Right, and this usually happens in older. What if this occurred in a younger person, like less than 30? Would you recommend them go see the ophthalmologist or a retina specialist?
Yes, I definitely can, especially if they're nearsighted. Because nearsighted, the more you're nearsighted, the longer you get the eye is, anatomically it's getting longer. The retina is a little bit more unstretched. And when that vitreous pulls itself forward, that stretched retina can easily be torn. So it's not usual in young people under 30. So if it does happen, definitely it needs to be thoroughly examined.
Okay, all right. Then the last question, except for medications, how can one control or treat gastritis? So Dr. Court, I know he's still there, and you can start off on this, but I know, different foods, any acidic food, obviously you want to stay away from acidic foods if possible. Try not to eat at least 2 hours before going to bed, so that you can give your stomach an appropriate time to empty, and you won't have that reflux during night. Try to sleep at a 30-degree angle. You can get something like a wedge to put in your bed that will keep gravity, will allow your stomach contents to stay down, so at least it's not refluxing at night. But there are other things like Maalox and Mylanta that decreases the pH of your stomach and allows for some of the acid not to build. And they're over-the-counter medications, as opposed to things like omeprazole and other medications that decrease the acidic production in your stomach. So these are some of the things that I'm thinking about. Dr. Court, can you expand a little better?
You've done very well, doctor.
But also,
go ahead, Doc.
Your eating schedule. Sometimes, guys like Dr. Daniels and myself, we're in the OR and we're there to 8, 10, 12 hours. That's a big gap. Short of doing some intermittent fasting or something. But the more hungry you get, the more acid production there is. So when your schedule is important.
Right.
The issue with gastritis, the itis, the ITIS means inflammation. And the stomach in general is designed to withstand high concentrations of acid. Hydrochloric acid, very strong hydrochloric acid, is produced in the stomach to help with digestion. So the fact that there's, and the acid is called a low pH, the fact that the stomach has a low pH doesn't necessarily mean that that's causing the inflammation. And so one of the things that sort of, I guess, over time, that hydrochloric acid, that low pH is designed to kill bacteria. And so it's sort of, to a certain extent, a protective mechanism. And once that fluid drains from the stomach, there's an offset to the acid. bicarbonate is released by the pancreas, which makes the pH neutral. But one of the things that has been associated with gastritis is an infection with the bacteria that somehow or another survives in that acid environment, and it's been thought to be responsible for causing ulcers. And maybe Dr. Carter, you can talk about H. pylori.
But I think the caller wanted to know of non-medications.
No. I didn't talk about medication.
No,
people talked about gastritis, but I'm not so sure that acid in and of itself is responsible for gastritis.
Right.
And also, so I was thinking about the H. pylori, if that is an issue that might be responsible for gastritis, then you have to talk about using something that might eliminate it, and that usually is medication.
Right. Okay.
And also the excessive consumption of alcohol, especially in folks who struggle with addiction, could be a cause of gastritis as well.
Yes.
Very true. Very true. All righty. There's a last question that I'm trying to understand, and I don't know if I'll read it, but I just don't understand it, and hopefully someone else could help me out with it. It says restarts, and then it down below it says restasis.
Oh, that sounds like an eye drop, no?
Yeah, it is.
Yeah,
yeah. I noticed this week that when I didn't use it, I had a burning sensation like a sore throat, but it wasn't it was not my throat. It felt like when you have drainage. So started using it again. I know it's late. What causes that?
All right. So the question is, when she stopped using the Restasis?
Yeah, she had a feeling as though, or he had, she had a feeling as though she had a sore throat, but it wasn't really a sore throat.
No, but it wasn't my throat. So now Restasis is an eye drop, right?
Yes,
so
it's an eye drop.
I suspect that she's saying that the irritation in her eye has the same sensation of a sore throat, but it's in the eye.
Yes, I'm not sure if I fully understand the patient, but Restasis is one of the treatment for dry eyes. So, initially when the eyes are dry, you use the over-the-counter artificial tears, Restasis, not Refresh or Sustain or some of the many other ones to use. But if those are not being effective, you can use these anti-inflammatory medications called Restasis, and another one called Xiidra. You'll see it advertised sometimes, and they do work to relieve the dryness to the eyes. But the patient it seems as if the patient is saying that when she stopped using the Restasis, the throat felt dry, and I'm not sure I fully understand that part as to why it would be dry if she stopped using the Restasis.
Now, the doctor answer a question. Is there steroid in that? Do you know if there's steroid?
No, it's not steroidal.
It's not a steroidal medication. Okay.
I thought the question was confusing, but the normal circumstances about the drainage of tears is that they go into the nose and go into the throat.
Right.
And some of those medications that are eye drops that can get into the throat, some I think have been associated with acid reflux. And so I don't know if there is a relationship between some of those drugs that might be associated with acid reflux, and what she's getting is sort of maybe a complication of that.
It's possible, especially if you're taking it at night, overnight. But yeah, I'm sorry for not being very clear on our answers, but
no, it was kind of we're guessing about what she means.
The question,
right.
Yes.
Right.
Okay.
And she's so kind. She said sorry.
Sorry,
but it's not. There's nothing to be sorry about.
Right.
I hope the answer is someplace there with whatever we said.
All righty. She's so kind. Oh, thank you. All righty. Dr. Anderson, you're up next. You got your hand up. Do you still have a question?
Yes. So more for Dr. Scott than Dr. Daniels, but Dr. Daniels could jump in. I mean, we now talk about AI, artificial intelligence, and how does that influence sensory perception, where it can now help us deal with another class of lenses for the eye, another way to sense light, contrast, hues, different colors, those kind of things.
We're into a field where it's uncharted waters right now. So AI can help us in a lot of ways. Even as an ophthalmologist, it can help us because looking at the retina and diagnosing even early diabetic retinopathy, an ophthalmologist can look in and take a while to try and find the early signs of it. An AI, which can look at millions or maybe even a billion different retina, can easily cite and diagnose diabetic retinopathy even quicker than an ophthalmologist. And I think the same thing would probably happen with mammograms. The AI might be able to diagnose breast cancer even quicker than a radiologist. So it's definitely in ophthalmology, it's helping us. And we're just basically just scratching the surface. How it's going to help us as far as our glasses and how we see well, to be determined. I'm not really sure myself exactly how it will be, but I'm excited. I'm looking forward to see how it can help me a better ophthalmologist. Or my help, well, I practice now with my daughter. She'll be the one that'll be making the diagnosis with AI, not me. But I am really excited to see how it can help us as clinicians and how it can help us as individuals, as patients.
Oh, excellent. We have Dr. Sprott and Dr. Salam. I didn't forget you, Dr. Salam, about sports and the eye.
Oh, yes.
Cover that. But Dr. Sprott, you're next.
Yeah, Winston touched on the two questions I had, and he mentioned floaters. And could you maybe help explain a little bit better what floaters are, and also the issues of retinal detachment and its causes and treatment?
Yeah, so if we go back to that vitreous, that gelatinous body in the middle of the eye, which is really attached to the retina. And as we age, it begins to shrink. And when it shrinks, it peels itself off from the back of the eye, the retina, and little cells within it start to float, and you can actually visualize them. Now, sometimes those little cells is just very benign, but as I said, sometimes when it peels itself forward, it can also break a little blood vessel on the surface of the eye, and what you may be seeing may actually be blood. So whether it's just a simple little benign floater, or is it actual blood that you're looking at, floaters is very important. You need to have it checked out. Now, again, when the gel pulls itself away from the retina, it can also cause a little tear in the retina. The tear in the retina can lead to fluid going underneath the retina and separating the retina, causing a retinal detachment. That neurosensory material is now separated, and that can cause a loss of sight. Now, when you suspect a retinal detachment, that if you even suspect it, it really needs to be looked at immediately, because you try to treat it before the macula gets detached. So retinal detachment is that separation of the retina. It can be treated. Sometimes if you catch it early enough, you can treat it right in the office with a laser. But if not, you may have to go to a vitreoretinal surgeon to fix the detachment. And it can be fixed, but it's time sensitive. Diagnosis needs to be made immediately. If your suspicion is high, let it be examined. Floaters, very benign after posterior vitreous detachment. However, if there is consistent floaters, it needs to be followed up immediately. If the patient is a diabetic, is it just a simple vitreous detachment, or is it a hemorrhaginous detachment? Is it a bleed in the eye? So especially in a diabetic, that should be looked at immediately. But for the average person, it's usually just the gel separating. It needs to be examined, but maybe not as acutely as someone who is diabetic or someone who's having persistent flashing of the light. Flashing of the light, that's electricity from the retina that's causing that, and that needs to be checked off because that may lead to a retinal detachment.
Can floaters be zapped or removed?
You know, it's being advocated by a few people. If it's debilitating to some people, most of the time we say leave it alone. If you leave it alone long enough, it'll settle down to the point where you don't even notice it. As an ophthalmologist, I have floaters. I had some floater in my left eye. When it happened acutely, even though I knew what it was was alarming. But right now, I don't even remember it. But some people, you know, they jump too quickly. They want it to be treated right away. There are some retinal doctors who are offering a service to treat it with a laser.
Depends
My general
on the kind of
impression,
insurance the patient has.
yeah, that could also do it. I usually tell the patients, you know, just be patient, leave it alone. It can be annoying if your eyes are thoroughly checked out and the retina looks flat. Check it maybe 6 months, but to subject yourself to a laser procedure, which is surgery, but any way you want to look at it, it is surgery. I don't advocate it.
Right.
And I think a retinal detachment is an injury seen in boxers as well. Is that accurate?
Yes. The trauma itself can cause a tear on the retina. And definitely, as you talk about sports injury, definitely. Lacrosse, that ball is hard. I've seen patients being hit in the eye with the lacrosse ball. They've hit with the stick, can also damage the retina. Football, even soccer, it may not damage the retina, but very often it hits you in the eye. It happened on a Saturday or a Friday, and over the weekend, it just becomes more and more painful to the point where you can't look at any light. Now it becomes it's an iritis, inflammation in the eye, and it needs to be checked out thoroughly. First, you want to check to make sure the retina is intact, and if it is, it responds very well to topical steroids.
Scott. Dr. Salam, was that it? Did you have any other questions?
And Dr. Scott, do you ever treat patients with nystagmus? And if so, how does nystagmus affect vision?
It depends on what's causing an nystagmus. Sometimes you're born with it and not a lot can be done about it. But first, when I see someone with a nystagmus, they need to have a thorough neurological examination.
Yeah. Dr. Scott?
Yes.
Can you tell us what the nystagmus is?
It's that oscillation of the eyeball. You look at someone, you notice their eyes are going back and forth, usually back and forth. Sometimes it can go up and down, but it's an abnormal movement of the eye. And usually it's related to some kind of neurological problem. So when I see it, I usually refer them to a neurological workup to make sure there is nothing else going on or something that can be treated. And if it's something just that they're congenitally born with, most of the time you do absolutely nothing.
Yeah,
Does it affect vision?
No, it's an involuntary motion of the eye. So there are reflexes, right? There are involuntary movements that we all possess, right? That are in some way controlled or augmented by our central nervous system, right? If I were to take a reflex hammer and I were to hit you on a tendon of yours, that tendon will cause your muscle to contract, right? You would have no control over it. That feedback mechanism is controlled in the spine, but it's augmented by the brain. So if you had an injury in your brain, that reflex would be more pronounced and it would be considered something called a pathological reflex. So just like those pathological reflexes, brisk reflexes, when you tap a hammer on your knee and your elbow, nystagmus could be completely normal. It is a reflection of the brain's ability to constantly monitor how both of your eyes are moving. And when the way you appreciate nystagmus in someone is you have them look a certain way and their eyes will beat in one direction and beat in the other direction as well. The vigor at which they beat gives you an indication of what direction the nystagmus is. which could be a reflection of something going on in the brain's ability to augment that movement, or it could be completely normal and physiological.
Or it could be related to the issues of the inner ear. People that have vertigo, positional vertigo, might have nystagmus when they change their position. If you take a small child and swing them around very, very quickly and you stop, then that fluid in the middle ears will keep going, and they'll have this, they'll stumble around because they're disoriented. So it could be an issue with the middle ear as well.
Yeah, so all it is just a sign that we check for on the neurological exam that might give us a hint as to whether there's something going on in the central nervous system.
Excellent, excellent. Dr. Clark.
Yes, I was wondering for Dr. Scott, if is it true that you can detect or diagnose retinal detachment by seeing showers of floaters rather than a single one?
Yes, and the more active those showers are, especially if it's associated with flashing lights. Flashing lights usually mean there's a little tug on the retina and you get a little electrical impulse that's causing that, because the retina is neurosensory tissue. So you definitely need to be examined. Don't just go by what is being said to you. But yes, the more vigorous those flashing lights are, and those showers of floaters, it needs to be examined. Initially, when you get that first detachment of the retina, it can be quite startling, and you will see showers of floaters, and you may even see a little light flash of light. But in the normal detachment, it'll get less and less and less. This is usually the vitreous now that's being detached from the retina. When the retina is being detached, that's much more serious. And you will see a lot of flashing lights and showers of floaters. And it usually is continuous. When the vitreous detach, it is a lot, but it tends to decrease over time. The retinal detach, it can continue or may even get worse.
Excellent. Now, just to let everyone know, we're running over time just a little bit. So if it's okay for another few minutes, I'd like to get Dr. Sprott he has his hand up, and then there's going to be one last questions about vertigo. Yeah. Dr. Sprott.
Yeah, Winston, almost everyone of a certain age starts to have cataracts, and we didn't spend a lot of time talking about cataracts, but if a lot of my siblings have had issues with cataracts, and they have these highfalutin trifocal lenses and all of this other stuff, and she had gotten set to have a surgery, and then there was some mix up at the office, and she went to another ophthalmologist and says, "Oh, your cataract getting bad enough for you to have surgery." So could you explain a little bit about what a cataract is, and at what point you might need to have surgery, and if you do, whether or not you ought to have a simple lens versus a fancy lens?
Yes. All right. So a cataract is, when you're born with a lens in the eye. And in fact, it's called the crystalline lens. As a child, it's crystal clear. Everything is nice and bright. With normal aging, that lens lays down cells over time, and the lens gets thicker and thicker. Just like you look at a tree trunk, you cut it in half, you see all those rings, those concentric circles in the tree trunk. You can almost guess the age of that tree trunk. Well, that crystal lens that you were born starts getting thicker and thicker, and light doesn't go through it as easily. It develops little opacities on it, cortical changes on it. And now we call it a cataract. And what the cataract is, it no longer allows you to function as clear, to focus as clearly as you used to. Because it's so dense, when you go out at night, the light doesn't go through it as well. Things tend to look a little darker. Most people don't like to drive at night. Those little opacities on the lens, the bright light hits it, you get a lot of glare. The lights these days in cars are brighter than they've ever been before. So now when it hits your cataract, you get more streaks of light. Now, everyone on this earth, if you live long enough, we're all going to develop a cataract because the lens is going to get so thick that it's not going to be able to focus as well. Now, what to do about it depends on how much is it interfering with your daily function. So whether you need to have surgery or not depends on, personally, how much is it bothering you? Can you read like you normally read? Is driving at night becoming more and more of a problem? And that's more and more is becoming a reason for people to go to have surgery, is they can't drive at night because of all that glare and light. So what to do with just because you have a cataract does not mean that you need to have surgery. So you really need to subjectively decide how much is this interfering with my daily function. And that's when you decide whether you need to have a cataract or not. Now, what type of lens implant you have, because when you remove a cataract, you're going to remove your lens, your focusing mechanism. It has to be replaced by a lens implant. Everyone who who has a cataract surgery, it needs to be replaced with a lens implant. Now you have what's called premium lens implant. You can have a regular lens implant, which is called a monofocal lens, which will allow you to see great see great for distance. Reading may become a little bit of an issue. So you may need to wear regular glasses. Sometimes just the dollar store glasses may be satisfactory after you have had your monofocal lens implant. Now, some people don't want to deal with glasses at all. They want to have a lens implant that will allow them to see not only distance, but also to read. So those are called premium lenses, which the insurance does not pay for. You're gonna have to pay for that yourself. So that may allow you to see distance and near. Now those premium lenses, it comes with a little bit of a problem in the sense that when light hits those concentric circles on the lens implant, it can also cause glare itself. So if you're one that tends to have glare when you drive at night, you may be very careful about getting a lens implant, which could possibly also cause glare at night. So you can get a regular lens, which is monofocal, will allow you to see distance. And even today, some of the monofocal lenses are such that they can allow you to see distance and also allow you to maybe look at your phone or something from a distance, but not to read really fine print. So it depends on how sophisticated your visual requirements are, and whether you want to wear glasses or not will determine which type of lens implant you want. Then the other thing to consider is what type of cataract surgery do you need? You can have a traditional cataract surgery where the doctor does everything, or the more state-of-the-art is where the laser is used to do those most difficult parts of the procedure. The laser could actually decrease the chance of complications. Depends on what type of cataract you have, how dense it is. It can help to decrease the chance of complications. So the laser is something that I strongly advocate to make your surgery less complex. The lens implant, you need to be determined by whether you want to wear glasses yourself or whether you're happy with wearing a little over-the-counter glasses or regular glasses after cataract surgery. That's a mouthful.
AI has an ability to improve the lens that God made for us, right?
No, that lens, a young lens, someone 25 years old, someone 30 years old, we can never get a lens as good as that. The lens implant is our attempt to try and get as close to it as possible. But those lenses that allow you to see near and far, you have to remember that sometimes light can affect them and you can get glare. They can themselves cause glare in some people.
Yeah, but Dr. Scott, if you can help me remember, the focusing mechanism, there's a muscle that attached to both like edges of the lens that allows it to become thinner or thicker depending on so that's the mechanism behind near and far-sighted, right? Mm-hmm. But the cataract has to not do anything to do with that muscle or the lens ability to become thinner or thicker, but what goes on within the substance of the lens itself. Right?
Yeah, the light.
Can you differentiate for me? Yeah.
Yeah, the light that has to go through that lens is being affected by that cataract. It's not a nice clear crystal that the light is being diffracted in different directions because of that lens, which has now become a cataract. It has the opacities on it. And there's a certain type of cataract called a posterior capsular cataract, where it's in the middle of the lens, where the light would actually come to a cone on the lens. There's an opacity right there. Those are very debilitating when it comes to reading. So it depends on the type of cataract you have, and it depends on your age also. But yes, it can be very debilitating.
All righty, thank you very much. This has been a wonderful show. I know that there are several questions that came up. I'm sorry that we don't have time to get those last couple questions. Please come on next time and pose those questions again. We'll get those answers to you. And also, I would recommend, if you come onto the program, get the questions in early so that we make sure that we answer them for you. Number 1, number 2, and number 3. Again, thank you all the physicians that were here today. I know that some of the physicians out there, they had some really urgent things to take care of, but we're looking forward to them joining us next time. All righty. In closing, thank you, OBHealthy, for allowing us to use your platform so that we can bring this program to you. I would like to say, Dr. Daniels, I'm sorry I didn't mention this earlier. Dr. Daniels is having a symposium next Saturday. Is it Saturday? You're on mute, Dr. Daniels.
I'm sorry, it's Saturday, the 16th.
Yeah, please tell us about it. Tell us, this is so important.
So it's a symposium on a phenomenon called hydrocephalus. It's an annual symposium we do in New Jersey, the first in New Jersey. We do it with an association called the American Hydrocephalus Association. There's 2 million people in the United States that have hydrocephalus. So it's designed to educate, patients, family members, and people who are just overall interested.
Excellent, excellent. So please, if you are interested in neuroscience, that's one thing you had talked about. Anyone interested in neuroscience or neurosurgery, please, how do they attend that surgery? How can they connect with it, Dr. Daniels?
There's a link. It's a fairly long link. I wish I could post it here, but I can't post it here. But maybe I can
post it on the OBHealthy.
Yeah.
Yeah. You could do that. Please, we'll try to post it up so that Dr. Daniels, we can get that connection and make sure that if anybody wants to attend, definitely we can get it together. Thank you. Note that we are here every second Saturday, except when we're on vacation, like August. But we are here every second Saturday at 1 o'clock. Please let friends and families know. It's all about improving the health of people of African descent, and that's what we're all about. And I'm going to say this, and this is I should start off the way the way I start off. This is the most important thing that I can say during this whole webinar, is that please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can appropriately treat you for your medical problems. All righty. And if you want to see our past webinars, please just go to OBHealthy, hit the YouTube sign, take advantage of the past webinars. Again, I thank all the brothers that are here today. Excellent job, Dr. Scott. I just can't even say enough about you, brother. Excellent, excellent. And thank you. We're going to have to get you back. You know that. I'm going to be pulling at your coattail to come back. All righty. So thank you. And we will see you next month. Until then, peace, everyone.
Thank you. Peace.
Hey, Omar.
Yes.
Could we hang around just for 1 second? I want to mention something to the brothers.
All righty. Just hold on just for a second. And yeah, hold on. What happens is, Ken, we may have to give you a link to come back in.
Okay.